Even though we're running behind schedule, we have some more questions for you. I just work here. I don't make the rules. The first question is, what country do you practice in now that we have a full audience? Maestro? Well, we are represented again for the second time by China being in the lead, I guess, followed by India and then Taiwan. And next question is, what is your gender? If you haven't figured it out by now, you're in big trouble. Maestro. We need a new tune. Yep, there's still more males here. That's very comforting to know. Your age is, let's go, Maestro. Well, you all reach middle age, I guess. I guess the majority of you are, in fact, between 40 and 60. What is the age of newly diagnosed AML in your practice? 1, 20 to 40 years, 2, 40 to 60 years, or 3, greater than 60 years of age? Maestro? So most are between 40 and 60. Not most, but a large plurality. Next question. What is the age of newly diagnosed multiple myeloma patients in your practice? Maestro? Well, it is indeed a disease of the elderly. I think it would have been more appropriate if we'd have asked for over 70, because that's, at least in the United States, where we have the cutoff for transplantation. Next slide is, what is the age of newly diagnosed CML patients in your practice? 1, 20 to 40, 2, 40 to 60, and 3, older than 60. Mostly between 40 and 60. That's pretty much what the past literature says as well. What is the age of newly diagnosed ALL patients in your practice? 20 to 40, 40 to 60, or greater than 60 years of age? Most of them are young, 20 to 40, not surprising. Okay, what is the age of newly diagnosed lymphoma patients in your practice? 20 to 40, 40 to 60, or greater than 60 years of age? So most of them fall into the 40 to 60 age category as well. And mercifully, that's the last of the questions. Now, I just want to make some more announcements, so while you're all here together. First is that the AFCON booth will supply you with a free membership if you're registered for this conference and if you'd like to become members of the AFCON. 2, please remember that UBS drives are available to you at the registration desk. All you have to do is fill in a few questions. 3, an AFCON meeting will take place between 5 and 7 p.m. in the JW boardroom, which is in the 30th floor in room 3002. And the president's reception, which will have a buffet, entertainment, and posters all together, will be in the JW California room, which is on the 5th floor. Everyone come. I think you'll have a very good time. Now, this afternoon, we'll have 2 separate simultaneous sessions. There'll be 4 sessions apiece. You can take your pick. However, those people who have pre-registered will get preference if the room fills up. And now, without further ado, I'd like to introduce our next 2 chair people. One is Professor Donna Weber from the MD Anderson Cancer Center, and Dr. Chung, Professor Chung from the National University of Singapore, who will talk to us about multiple myeloma. Gentlemen.
Okay, so we better get the myeloma session started. For the first speaker, we have Dr. Ravi Vij from Washington University, and he's going to talk to us about newly diagnosed myeloma, whether the use of doublet or triplet therapy would be best.
Thank you very much to the organizers for the invitation, and especially Simrit, who's done a great job in putting this all together. So I guess the title got a little abbreviated. The one given to me was doublets versus triplets, and also role of risk stratification. So we'll go ahead and get started. So let's see. Do I just go here? Oops. How do you advance it? Okay, thank you. So certainly we made great progress over the years in the treatment of multiple myeloma ever since the introduction of melphalan and prednisone in the 60s to subsequently the introduction of stem cell transplant in the 90s. And then the next major uptick after the turn of the millennium came from the introduction of the novel classes of drugs, proteasome inhibitors, and immunomodulatory drugs. And hopefully, in another few years, we'll see a further uptick with the approval, at least in the United States, within the last 6 months, of two novel agents, carfilzomib and pomalidomide. So the issue of doublet versus triplet is largely driven by the issue of complete remission. And this is something that continues to be a debate. Some people feel that serial use of agents reduces toxicity and provides perhaps the same survival benefit. Others feel that CR is a good surrogate for overall survival. The majority of the data perhaps does support the latter contention, though I think there is still some controversy in this area. Not only about CR being an adequate surrogate for survival, but also are all CRs as durable. We know that certain CRs from chemotherapy regimens may not be as durable as that produced by stem cell transplantation. Also, the definition of CR, as we will also talk about later in one of the breakout sessions, continues to evolve, and a lot of these CRs are EBMT CRs and IMWMG CRs, and going forth, more stringent definitions of CR may produce different answers. Should we strive for CR pre-transplant? What is the role of transplant for people who are in CR pre-transplant? So these things are all open questions. Just a slide to say that there is data to suggest that CR does improve the overall survival of patients who undergo stem cell transplantation, and that better depth of response, both pre and post-transplant, leads to better outcomes. Not only in the younger population, but even in elderly multiple myeloma, it has been shown that the depth of remission does seem to correlate with survival. This is from an article in Blood showing that the progression-free survival and overall survival of patients in CR was superior in elderly patients with multiple myeloma. So, having tried to convince you that CRs may be worth striving for, what is the treatment approach for patients with myeloma? I think most people still would agree with this algorithm that if you are a potential transplant candidate, then avoid alkylator-based therapy and then go at least to a stem cell transplant, or if you ask a transplanter, proceed to transplant. I think we may have some discussion on early versus late transplant later in this session. For those who are not transplant candidates, conventional therapy, which continues to evolve, is the right answer. So as regards the issue of 2 versus 3 drugs in the pre-transplant setting, there are a number of data sets that tell us about our modern regimens, Revlimid, Velcade, Decadron, Velcade, Cytoxan, dexamethasone, and more recently carfilzomib, Revlimid, dexamethasone, in which a proportion of patients went to stem cell transplantation. However, they are not randomized data, so I don't think I'll be discussing too much about those. I'm just putting up those that are randomized clinical trials for the remainder of this discussion. So essentially, coming to the issue of 3 versus 2 drugs, we can make some judgments based on the data with bortezomib. And this is the data from 2 different trials, Velcade thalidomide dexamethasone versus thalidomide dexamethasone, and abbreviated Velcade with thalidomide dexamethasone versus Velcade dexamethasone. And what we see is a fairly consistent pattern that when you give the 3-drug regimens, you get a better CR plus very good partial response rate. And progression-free survival with early follow-up also appears to be starting to be superior for 3 drugs versus 2 drugs. What we lack at this time is the overall survival benefit. Unfortunately, that may take a few years to evolve. So either you could be in the camp of, I go with data and I will wait for the data to evolve before I change my practice, or you can say that since CRs are mostly a surrogate for survival, then perhaps we should go with 3 drugs. Certainly in my own practice, we do go with 3-drug regimens, but it's mainly Velcade, Revlimid, Decadron as the favorite. Moving to the elderly patient population, the question of 3 drugs versus 2 have been addressed with a number of our novel agents. So this slide summarizes 6 trials from a meta-analysis done and published in Blood last year, actually 2 years ago now, that looked at the issue of whether thalidomide adding to melphalan and prednisone improves outcomes. And these trials, I won't go into the fine print, were somewhat different in the duration of use of thalidomide, the doses of melphalan use, but broadly, I think, do provide a concrete data set to make some conclusions. And the conclusions that were reached were that though only 2 studies showed a survival benefit on their own, when you do a meta-analysis, it did favor the use of 3-drug combination of melphalan, prednisone, thalidomide versus melphalan and prednisone. So this was statistically significantly superior. The issue then about Revlimid. So this trial, which has been published in the New England Journal by Dr. Palumbo, now nearly a year ago, I believe, looked at the issue of adding Revlimid to melphalan and prednisone and comparing it to melphalan and prednisone alone. This trial was a 3-arm trial, which tried to answer also the question of whether maintenance Revlimid had a role. The primary comparisons were to be between MPR followed by Revlimid to MP. And in that regard, it met its primary endpoint, which was progression-free survival advantage. An overall survival advantage has not yet emerged with this trial. So I think that here we have 2 myelotoxic drugs, Revlimid and melphalan, and one should be ready to face some hematological toxicity and try to use liberally growth factors if one wants to give this regimen. What about bortezomib-based in transplant ineligible? Certainly everybody, I think, here would be familiar with the VISTA trial, which with 5 years of follow-up continues to show a survival advantage. And the other study shown on this slide is a study that still is preliminary, which is looking at the question of not only 2 versus 3, but trying to move away from melphalan-based regimens. And with this early follow-up, we have fairly similar response rate data and similar progression-free survival data. So we'll have to wait for longer follow-up on these studies. Now, this is the last study that we just went over, so we're moving to see if we can move melphalan from the regimen. Also, the question of 2 drugs versus 3 may boil back down to 2 drugs if we are able to show that a Velcade Dex or a Rev Dex regimen is equivalent to a 3-drug regimen containing melphalan. So I think we are still early, but we'll probably have data from this trial perhaps later this year, which is a trial that is looking at comparing melphalan, prednisone, and thalidomide to lenalidomide and dexamethasone. This trial also tries to answer the question of whether maintenance lenalidomide has any role. So quickly winding down now, the second question that was posed to me was to address the issue of risk stratification. Here, too, there is no consensus, and there's a lot of I think, heterogeneity in practices. What we have, however, come to realize is that we are probably making some progress against our former high-risk groups. So we used to have, in the MSMART guidelines popularized by the group at the Mayo Clinic, 2 risk groups in the past. Now that has been updated to 3 risk groups. So the high-risk group consists of deletion 17p, translocation 1416, and 1420, plus the gene expression profile that is commercialized by the group at Arkansas with a high-risk signature. Formerly, 414 and deletion 13 by cytogenetics was also considered high risk. Now, with the advent of proteasome inhibition, specifically bortezomib, it appears that the data suggests that this is no longer an adverse risk profile. The plasma cell labeling index, which is done in very few institutions, also seems to confer an intermediate risk. Standard risk are those that have hyperdiploidy on conventional karyotyping and have translocation 1114 or 614. So the slide I put up here is essentially the proposed algorithm by the Mayo Clinic. This is fairly empiric based on literally no data. This is a consensus statement of their 20-odd myeloma specialists, and I think that very few people perhaps follow this algorithm to the letter. But what they're trying to do is personalize medicine to risk stratify, and I think it's a valid attempt. So for patients who have standard risk disease on the extreme right-hand side, they feel that even a 2-drug regimen may suffice for the induction, and then it is left to the treating physician whether they wish to consider an early transplant or to continue on Revlimid and Decadron after the stem cell collection. For intermediate risk, they favor their CyBorD regimen, which is Cytoxan, bortezomib, dexamethasone, and then take patients to stem cell transplant, and they favor giving a bortezomib-based maintenance therapy. The high risk, they favor 4 cycles of Velcade, Revlimid, Decadron, an auto transplant, and then VRD maintenance for 1 year. As I said, not many people, I think, follow this algorithm. I think in the high-risk subgroup, we know that the risk of relapse is early. The response rates are the same. So it does make logical sense to try to be more aggressive with maintenance. And since proteasome inhibitors seem to be the better drug for that group of patients, the bortezomib-based regimens are what are emphasized. So just to conclude, 3-drug regimens are associated with higher CR rates compared to 2-drug regimens. In the transplant-eligible population, prospective trials have shown a higher CR rate and higher progression-free survival for 2-drug regimens, or 3-drug regimens over 2-drug regimens. However, follow-up is too short for overall survival analysis. In the transplant-ineligible population, 3-drug regimens of thalidomide and bortezomib have shown overall survival advantage compared to melphalan and prednisone alone, which for a lot of people is not an adequate comparator. But whether non-melphalan containing 2-drug regimens may be equivalent is the subject of ongoing clinical trials. And we do seem to have entered an era of risk stratification for deciding therapy. However, no consensus has emerged on treatment paradigms. Thank you very much.